Three words that describe me. Oh, that's a tough one. I tend to be calm, rational, and I try to be empathetic. My name is Dr. Robert Horowitz, and I'm the medical director at the Junee Nyland Cancer Center. Colon cancer is very common. About 1 in 25 people will end up getting colon cancer in their lifetime, and it is the second most common cause of cancer death in men and women, so it's very common. Things that people should be aware of would be blood in the stool, change in bowel habits, abdominal pain. Those would all be concerning. Certainly older folk have a higher incidence of colon cancer, although it has been rising in younger people as well, sometimes even unusually young people. Certainly people who have a family history of colon cancer or polyps are at increased risks, and certainly anybody with inflammatory bowel disease, Crohn's or ulcerative colitis would also be at increased risk and would probably start screening earlier. Really the key with colon cancer is that we believe that it goes through stages. First, someone develops an abnormal growth or a polyp, then the polyp becomes abnormal, and then eventually it turns into a cancer, and that cancer eventually grows and invades and can spread to the regional area, the lymph nodes, and then eventually can spread to distant organs. So really the key with colon cancer is that if you can catch it when it's just at that polyp stage, with a colonoscopy you can have it removed and then hopefully never get to those later stages and maybe never get colon cancer. These kinds of things are always in flux, but certainly by age 50, everyone should be screened. Some of the guidelines even say 45, as early as 45, and certainly if someone has a family history or any of those inflammatory bowel diseases, then certainly you would want to start screening earlier. Certainly if you had any symptoms like the ones we described earlier, like blood in the bowel movements or change in bowel habits, then you would want to get screened earlier. They actually wouldn't be screening at that point. Screening would only be for asymptomatic people, but you certainly want to get evaluated sooner if you had any of those symptoms. I definitely would encourage people to get screens. There are a lot of different ways to get screened. So there are various stool tests. There's also various scopes, sigmoidoscopy or colonoscopy, and certainly there's a lot of debate as to what's the best way to be screened, but certainly I think the most important thing would be to be screened in some way, and people should really be talking to their primary doctors about how they should be screened and when they should be screened based on their risk. If someone gets diagnosed with colon cancer, usually the next step would be staging. So to try and figure out, does this look like it's something more localized, or does this look like something it might have spread? Very frequently, surgery is an initial step if it looks like it's more localized. And then depending on what's found at surgery, then a person might be offered additional therapies like adjuvant chemotherapy. So adjuvant is in addition to, in case there is any microscopic spread. There is a little bit of a difference in the treatment between rectal cancer and colon cancer. So the rectum is the very lower part of the colon and is more in a fixed area. So radiation frequently has more of a role in rectal cancer. So it really depends on the location and the stage as to what treatments a person gets offered. Well, I really think we provide state-of-the-art, guideline-based, multidisciplinary care. So I really feel that if patients are coming here, they're getting the best standard care that a person could get. I think the most rewarding part of my job for me is helping patients to understand their disease so that they can make the decisions that they need to make. That's a very gratifying thing, is to help people to understand what's going on with their bodies and their medical condition.